So welcome everybody, and thanks for joining us for this, which is the latest in the Association of Physicians webinar series, Emerging Issues in Medicine. My name is Rachel Myles. I'm an academic cardiologist from the University of Glasgow and a member of the association. Our webinar today is going to explore the role of the post-mortem examination in modern medicine. And to do that, we're going to hear from three really fantastic speakers who are going to outline new developments in autopsy and really look at how this age-old medical examination is still evolving and is still providing us crucial insights that are helping us to advance patient care. We were due to be joined by Professor Jo Martin to co-chair with me today, but she's unfortunately unable to join us. And Dr. Esther Youd from the panel has kindly stepped in and will join me in co-chairing the panel discussion later. I think it's fair to say that our panel members are all keen to hear your thoughts and to answer any questions you have. So please submit these using the chat function during the talks, and we will get to those during the panel discussion. So we've got a packed programme, so we shall press on, and I'd like to start by introducing Professor Elijah Behr from St George's University in London, where he leads the cardiovascular clinical academic group. Throughout his career, Elijah's clinical and research work has really focused on the investigation of sudden cardiac deaths using a multidisciplinary approach to identify families who are affected by potentially lethal and devastating inherited cardiac conditions. It's true to say that he really is one of the founders of the clinical expertise that we have in this field. I'm biased because this is where I work also, but it truly is fascinating. His expertise is reflected in his national and international reputation, his contribution to international guidelines in this area. And he's now leading a really exciting and I think important body of collaborative work with the BHF, the NHS and the Coronial Service in England to support the practical adoption of this work here in the United Kingdom. I think on a personal note, Elijah's work inspired me and I think many other cardiologists to get involved with inherited cardiac conditions. And I'm really delighted to welcome him and to invite him to give his talk on molecular autopsy in the investigation of sudden cardiac death. Elijah.
Thank you very much, Rachel. That was a really kind introduction. I really appreciate that. And thank you for asking me to speak today. I'm just going to share my screen, which should be up and in place.
Perfect.
Great. Okay. And so I'm really delighted to be able to speak today at this seminar, at this webinar, get it right. And I'll be talking about molecular autopsy and the investigation of sudden and unexplained death. And I'll be referring in particular to, let me see, I'm hoping that you are seeing what I'm, there we go. Okay, we're on our way. I'll be referring in particular to one of the more recent international documents published in this area that I was able to contribute to from the Asia Pacific Heart Rhythm Society and the Heart Rhythm Society, with contributions from the European Heart Rhythm Association. And the context is one of particularly young sudden death, where we see the relevance of genetic heart diseases mostly. If we look at this Irish study, which is pretty typical of the experience in general, but it's a very nice population study of young sudden death, so that's under the age of 35, or ranging between 1 and 35. There are a number of different causes that are discovered by autopsy in general, and these are usually inherited or genetic, or have an inherited or genetic component in them. And so the ones that are most typically picked up at autopsy are the cardiomyopathies, hypertrophic cardiomyopathy with left ventricular hypertrophy or potentially of unexplained origin, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, sometimes more termed now arrhythmogenic cardiomyopathy because of left ventricular involvement as well. Then premature coronary artery disease, often related to familial hypercholesterolemia, aortic dissection and rupture related to familial thoracic aortic aneurysm disorders and syndromes. And then another group, the largest group overall, which is SADS, sudden arrhythmic death syndrome. And I'm going to explain what that means at the moment, but all of these have potential inherited or genetic bases. And back in 2013, an expert consensus made recommendations internationally on how to use terms diagnostically. And in particular, they used the term sudden unexplained death syndrome to describe an unexplained sudden death occurring in an individual older than 1. And if an autopsy was undertaken and toxicology undertaken, and both found to be negative, and the death therefore remains unexplained, then the term sudden arrhythmic death syndrome was applied. So SADS is a pathological diagnosis of exclusion. And arrhythmic is using the term just to flag up the possibility of arrhythmic disorders and syndromes, although we don't expect that all of these are caused by arrhythmia syndromes. So this is the process that is undergone, and the place that genetic testing will take in the process is very important. So sudden unexplained death syndrome undergoes pathology, which is recommended. And it is also recommended that tissue at the time is taken for, that is suitable for DNA extraction. And if possible, expert cardiac pathology, although that's not always readily available. Now, if we see evidence of extreme hypertrophy, such as this typical pattern of global hypertrophy with asymmetric septal hypertrophy, and underlying it on histological analysis, disarray and fibrosis, where we see the myocytes disturbed by clear fibrotic tissue in a disorganized pattern, then this is typical for hypertrophic cardiomyopathy, and the diagnosis is made. Alternatively, we may find evidence for fibrofatty infiltration, particularly affecting the free wall in the right ventricle, but may also be affecting the left ventricle, or even the left ventricle independent of the right ventricle. And this is fibrofatty infiltration, and the fat cells here with fibrous tissue surrounding them, making a diagnosis of arrhythmogenic right ventricular cardiomyopathy in this case. And then dilated cardiomyopathy, where there may be dilatation of left or both ventricles, where the pattern is more of fibrosis and an end stage of multiple disease processes, of which many may be genetic, where we have this fibrotic replacement of normal myocardial tissue. And so if we do have a potentially inherited disorder diagnosed, and particularly cardiomyopathy in these cases, then one should instigate appropriate evaluation in the clinic, and then undertake post-mortem genetic testing targeted to the phenotype. And while there have been 1 or 2 small studies related to this, I'm just going to highlight one that I was involved in. And here we had cases from a case series originating from Mary Shepherd, my colleague at St. George's, where we undertook genetic testing in retained tissue in cases associated with structural disorders such as the cardiomyopathies. You'll see a smattering of arrhythmogenic, dilated and hypertrophic cardiomyopathy, and we find what are termed pathogenic or likely pathogenic variants, genetic variants or mutations that are likely to be disease-causing and therefore immediately usable or actionable in family members. And that's at least 1/3 of cases there, while there are variants of uncertain significance found in another 1/5 of cases. So here you can see there's already immediately a diagnostic yield from genetic studies that would validate that approach of using targeted genetic testing. Now, if we have an unexplained sudden death, the SADS, case where the autopsy, toxicology, and the expert pathologist assessment has been negative, a particular focus is taken on working up the personal family history or circumstances of the sudden death, because that may give more clues as to the etiology. Is there other family history? What were the circumstances? Could there be markers of other diseases? And then we may go on at that point to undertake a post-mortem gene test or molecular autopsy, as it's now called, for suspicious phenotypes. But while that is recommended, if there are no particular pointers, one may still go ahead and undertake a molecular autopsy for all cases, because it could still be useful. and that's why it's a class 2A recommendation there. I'm going to touch a little bit more on whether we would consider cardiomyopathy genes as well as part of that panel, but that's maybe something we can consider for discussion. I'll again just show some research that underlies this. So here is an example of this, a series of SADS cases, over 300, where we undertook a large panel of genes, including cardiomyopathy genes, where we found 13% yield of immediately diagnostic likely pathogenic or pathogenic variants that would be used for clinical utility. Please see that there are variants of uncertain significance still that may be useful in families if they're evaluated properly in the right sort of service. The molecular diagnoses may particularly arise in inherited arrhythmia syndromes such as catecholaminergic polymorphic ventricular tachycardia, and this is earmarked by the gene RYR2, which is the gene involved. Then you can see also evidence for long QT syndrome being present on this series, as well as Brugada syndrome and cardiomyopathy. So quite a range of genetic targets there. If we then look at families and how this helps with diagnosing families, we looked at a subset of around 80 families where we did see them in the clinic from those 300 cases. And you'll see we had the diagnosis of Brugada syndrome in the family on clinical grounds. But if we then added in post-mortem gene testing and cascade testing in the family, we were able to make diagnoses of long QT syndrome of increasing frequency here from 4% to 7%. CPVT increased from 5% to 10%. We were able to identify cardiomyopathy as well as a cause of death, and found evidence of it in family members with that extended testing, as well as, of course, having that residual diagnostic yield of Brugada syndrome predominantly on clinical grounds. And so combining the use of molecular autopsy with family evaluation is not only valuable in itself, but also increases the yield for family assessment by about 50% or so to around 40%. So it's no surprise that if we do find a genetic variant that's pathogenic or likely pathogenic, that is recommended that we use it in family members, and it's a class 1 recommendation. So in conclusion, genetic conditions underlie sudden death in the young, and molecular autopsy has important roles to diagnose the etiology in SADS cases and to confirm etiology in structural heart diseases. And this allows us to identify relatives at risk in particular, enhances our diagnostic yield, and gives a much more synergistic evaluation of the family overall, and hence its importance in the guidelines. And if you have any other interest in sudden death genetics and cardiac arrhythmia genetics, please consider joining the European Heart Rhythm Association and the ECGen focus group of the European Heart Rhythm Association. Thank you for your attention.
Thanks, Elijah. That's a really fantastic summary of a fascinating area, and I think one that's so truly multidisciplinary, and lots of things for us to discuss in our panel discussion at the end. And thanks also for keeping to the stringent timings. That was impressive to do. So next up, I'm delighted really to introduce our second speaker and my co-chair, Dr. Esther Youd. Esther is a consultant autopsy pathologist here at the University of Glasgow and has specialist interest in sudden cardiac death, in maternal death. And during the pandemic, Esther really turned her expertise to the issue of COVID-19, publishing in June 2020 the first series of autopsy findings from UK patients who died in community settings of COVID-19. She's a really powerful advocate for pathology and its role in medicine, and that's reflected in her role as Assistant Registrar for the Royal College of Pathologists and her appearance in the Pathologist Power List of the 100 Best and Brightest in 2018. So I really can't think of anyone better to represent pathology in this really cross-disciplinary session focused on autopsy. Esther is going to talk to us today about the role of post-mortem examination in tackling the COVID-19 pandemic. Esther, thanks so much for joining us. Over to you.
Thank you very much, Rachel. That's a lovely introduction. I'm just going to share my screen. Okay.
Perfect.
So, as Rachel said, I'm an autopsy pathologist in Glasgow. I'm a bit of an unusual pathologist in that I trained as a histopathologist, worked as a histopathologist for 11 years, and then I decided that my main interest was autopsies, and the perfect job appeared for me up here in Glasgow. So here I am. So I'm going to try to convince you that autopsies are a worthwhile study for us to understand disease, and not just an ancient practice that we should get rid of and replace by scans. The talk on scans I'm really excited about, but there's definitely something about examining pathology in your hands and learning from it. So there have been many studies over the last few years that have looked at how good autopsies are and really compared them to death certification and how good death certificates are. And study after study showed that there are huge discrepancies between what clinicians think is a cause of death and what might be found at autopsy. And this was one of the latest publications back in 2005, which was a meta-analysis of all of those previous studies, which said that at least a third of death certificates are likely to be incorrect, and that 50% of autopsies produce findings that are unsuspected before death. And a fairly large proportion of those are things that would change your understanding of what happened to somebody and the cause of death. Of course, thinking about the COVID pandemic, when you've got a new organism and a new disease, the value of an autopsy is about learning about that pathophysiology in order to inform care for the living. And I think that's really important, a really vital role that pathologists can play when you have a new disease that emerges. At the beginning of the pandemic, pathologists were doing autopsies and discovering people who had died of COVID. But there were very few centres that were performing consent autopsies in patients that are known to have COVID. And I was one of those. I was quite fortunate in where I previously worked down in South Wales, that we managed to get a research study up and running really quite quickly. And I'm ever grateful to the families who agreed and gave their consent for us to do autopsies on their loved one who had just died from COVID, so that we could study the effects immediately, but also that we could take tissues to be able to be studied in more detail, research studies, and those tissue samples are being shared across the UK and even potentially across the world, so that we can learn about the effects of COVID. So this is what we were seeing. Obviously, COVID particularly affecting the respiratory system. So we were mainly seeing findings in the respiratory system. In the trachea, we were seeing lots of inflammation, and that fit with what ITU colleagues were seeing when they looked down at the trachea. They were seeing lots of tracheitis. We'd often see purulent sputum, and that was particularly if you had a superimposed bacterial pneumonia. And I saw that where people had underlying chronic lung disease like COPD. The lungs themselves are heavy. They often weighed 700 or 800 grams each, or even up to 1,000 grams. And when you compare that with normal, is about 350 or 400 grams. So they were particularly heavy lungs. They felt firm, and the picture here shows a pair of lungs that are basically standing proud. The lobes look really firm and engorged. They're standing proud off the dissection table because they're so solid. We were seeing red or grey hepatization, which I'll show you an example of on the next slide. We were seeing pulmonary edema, and we were seeing pneumonia, as I've said, if you've got a superimposed bacterial infection as well. This is what grey hepatization looks like. This is a very old-fashioned pathological term that is usually describing somebody with a lobar pneumonia. And essentially, it was a term used because the lungs began to look like liver. So they looked very firm, and they looked very dark red, like liver. And here you've got a bit that looks kind of dark red and a bit that looks more greyish, and it becomes more grey as it progresses. So we were seeing lungs that looked like lobar pneumonia, but it wasn't lobar pneumonia, it was ARDS. So looking at the microscopic features, we were seeing diffuse alveolar damage in the lungs, and that's the histological correlate of ARDS. We saw these pink fibrin membranes that were lining the alveoli, and that's a feature of diffuse alveolar damage. We were seeing features of viral pneumonitis, so thickening of the walls of the alveoli, of the interstitium, and an infiltrate of lymphocytes. But all of these features are not specific to COVID-19. You can see these in other viral causes of pneumonia. So because we were testing at postmortem so frequently, we were picking up other viral causes of pneumonia. So I frequently saw cases of rhinovirus or human metapneumovirus, and you could see similar features of diffuse alveolar damage in those cases, although many of the COVID cases had more advanced disease. Here you've got a picture just to remind you what normal lung looks like, with the very, very thin alveolar walls. And then on the right, a completely distorted alveolar structure with, again, these pink membranes lining the alveolar walls, with thickened interstitium with lots of lymphocytes, the purple small dots. And then type 2 pneumocytes being sloughed off and shed into the alveolar spaces. So all features of diffuse alveolar damage and viral pneumonitis. This is an appearance of a late stage diffuse alveolar damage where it's now organising. And you can see these clumps within the alveolar spaces. We were also seeing pulmonary microthrombi. These weren't thrombi that were coming, that were embolizing to the lungs from DVT. These were thrombi that were forming within the lungs. This wasn't necessarily a surprise when we were first seeing them, because you commonly see microthrombi in the lungs in diffuse alveolar damage of many causes. So it's not necessarily a surprise, but clearly there's been a recognition of increased thromboembolic events in COVID. We were also seeing vasculitis. These are two examples of inflamed arteries, but this is a secondary phenomenon, secondary to the diffuse alveolar damage. In the kidneys, we were also seeing microthrombi in the glomerular capillaries, but again, this is something that is commonly seen in other causes. For example, in sepsis, in DIC, then you can see this type of microthrombus in the glomerular capillaries. I had to put this slide in though because it's so pretty, and it involves my favourite stain of all, which is MSB, the blue and red one at the bottom. So I just want to talk about the heart finally, because it was recognised really early on in the pandemic that patients coming into hospital had very high troponin levels. And from a pathological point of view, we were trying to figure out what the cause was. The clinicians were making the assumption that it was a myocarditis associated with COVID infection. But autopsy studies showed us what was going on. So I think that the autopsy was really key in trying to understand this. And most cardiac pathology that we were seeing was pre-existing disease. It was people with hypertension, with ischemic heart disease. There was a fairly common occurrence of amyloid in the heart. What we weren't seeing was myocarditis, and we weren't seeing pericarditis either. Just to explain, the photograph on the right is a heart showing pericarditis, but this is not a COVID case. It was just an illustration of what pericarditis looks like. So since the early part of the pandemic, pathologists have been particularly thinking about what's going on in the heart. And early on, there were cases published and described with the autopsy findings, and myocarditis was reported. And people had illustrated those with images that really didn't fit the criteria for diagnosing myocarditis. It didn't quite hang together. And many pathologists, and particularly cardiovascular pathologists, were trying to find out what the truth was. Was this really myocarditis, or was this just a confirmation bias of pathologists early on in the pandemic thinking, oh yes, here we've got a bit of inflammation, this must be COVID myocarditis. So over the years, there's been several large studies that have looked at this. The first, published by Christina Basso and a large group of cardiovascular pathologists, looked at a series of 21 cases. And these were, all of these cardiovascular pathologists looked at these cases and assessed them using standard criteria, and determined whether there was myocarditis or other myocardial injury. So it was a standard approach by a group of pathologists who were specialists in cardiovascular pathology. So something that you can really, take great reassurance from. And they did see some myocardial injury, but they didn't see true myocarditis, or at least it was very rare. The next largest study was 277 cases, so getting bigger and bigger. And again, they concluded that myocarditis was rare. And just hot off the press, the third study there is one that I also collaborated with, that's just been published this month, and has done a systematic review which covers 548 published cases now. And again, have concluded that myocarditis in COVID is rare. There's plenty of cardiovascular pathology that's seen, but not myocarditis, or at least it is rare. There isn't a specific pattern of histological COVID-19 myocardial injury that can be determined. So in conclusion, we get very striking lung changes in COVID-19, but they're not specific. So we need to have the confirmation of the virology studies in order to determine the true pathology. The cardiac changes, again, also not specific, but the take-home message being that myocarditis is rare. And finally, just to, I hope I have managed to convince you that autopsies are a valuable tool, particularly in understanding a novel disease. And clinicians, you can request postmortems. Obviously by talking with a family, if there's something that you want to understand a bit better about how somebody has died, whether it's COVID or something else, then please, get in touch with your local pathologists and talk to your family, talk to the family. And if you want to pursue that, that's something that is available. And many pathologists would really love to help you and support you with understanding disease better. Thank you very much.
Thank you, Esther, for a really fantastic summary. And I think I would really just want to echo that as a physician who now regularly talks with pathologists, you included. It's a really helpful thing to do, and absolutely that option is always there. So moving on, I'm very pleased to say that we're going to stay in Scotland for our third and final speaker, Dr. Siobhan McLaughlin from the the Royal Infirmary of Edinburgh. So a consultant radiologist in NHS Lothian, Siobhan has a specialist interest in post-mortem imaging, and she combines a busy NHS practice with work as a forensic radiologist. And she's really been instrumental in establishing an imaging post-mortem service in Scotland, which remains one of the few in the UK. So reflecting this multitasking, she's joining us today from the NHS, which, as many of you will probably sympathise with, computers that have both PowerPoint installed and a webcam are few and far between. So we won't be able to see Siobhan today, but it's an imaging talk. We had to prioritise the slides, so we will be able to see the slides and to hear Siobhan. And she's going to talk to us today about post-mortem imaging, the future of autopsy. Siobhan.
Thanks, Rachel. Can everybody hear me okay?
We can.
Perfect. Okay, I'll just share this screen. Okay, so as Rachel said, I am a consultant radiologist here in the Royal in Edinburgh. I've never been on a power list, which I'm now quite upset about. I didn't know that was a thing. But anyway, I've got a lot of slides and I'm a gas bag. So let's see how many we can get through in 15 minutes. So I'm just going to really briefly tell you about the Edinburgh service, how we use it, the applications of post-mortem imaging in general, and I'll see how many cases I can get through to show you. So I started the Postmortem CT service in Edinburgh in 2011. I should quickly tell you that in Scotland, the forensic pathologists handle both the suspicious and the non-suspicious deaths. So they cover what in England would be coronial and police work. It all comes under the same umbrella of forensic pathology. I currently do the imaging out of hours in addition to my NHS work, but I'm awaiting the go-ahead for a fully funded service. We cover non-suspicious and suspicious deaths, and we could also do a little bit of disaster victim identification, DVI. We also do RTA work, and these are the situations where postmortem CT can be quite useful. So hopefully I'll tell you a bit about that today. So
you know, the value of doing an autopsy in a sudden cardiac death, you know, particularly when this involves young people, and that's been really nicely outlined by Elijah. I hope I convinced you that, you know, it's helpful in understanding novel diseases. And Siobhan's talk, absolutely fascinating about postmortem CT. Can I kick off with the first question, actually, to Siobhan? I had some experience working with one of our local radiologists of doing some postmortem CT and learning together. And as you've said, the visualization of bony injury is something that's really valuable and much better than in many cases than we can do in terms of a dissection at autopsy. But we did find that there were some bony injuries that were perhaps better seen at autopsy and more tricky to understand at postmortem CT. And given that you've got more than 10 years experience, I wonder if that's something that you've kind of developed and learned along the way. The particular things that kind of spring to mind were visualizing basal skull fractures. And I guess it was the difference between the 3D image that we see looking from a postmortem versus multiple serial 2D slices that you see on a postmortem CT. I just wondered if that's something that you experienced or have just developed with your expertise over time.
Yeah, that's a really interesting point, Esther. So I've not had that feedback in my own practice, but we do know in general that CT is not great for basal skull fractures in the living. So even though we do loads of CT to confirm or deny it, the clinicians, if they think that's their level of suspicion, they're told to treat it, even if the CT doesn't show that. I have had some skull fracture patterns in RTAs that I've never seen before, like a hinge fracture. I'd never seen that before. I think a lot of the reason why we don't see fractures like this is because people don't live long enough to get to a CT scanner. So it is interesting in postmortem CT, you do see stuff that you don't see in your living population. And that was a learning point for me because the Royal, we're a major trauma unit, we're the only A&E, we've got a transplant unit, cardiothoracics. So I am exposed to quite a large volume of really quite acute and significant pathology. And I thought I knew all the ways there were for people to try and die, but of course I didn't. Hopefully when we get our funded practice and we're scanning so many more cases, we will see this. But yeah, basal skulls, CT is not great for, and that's, we know that anyway.
Thank you. And just to encourage people to please do contribute questions either on the chat or the Q&A, and we'll pick those up. Elijah, we've got a question here about gene prevalence that might, is there any evidence of increased prevalence of genes that might cause electrolyte disturbances amongst the SADS cohort? Have you got any experience of that?
No, not as yet, no. There are funny, well, they're not funny, but there's a real rag bag of genes involved in that sort of management, and occasionally you see odd things cropping up on molecular autopsies that involve exomes when you're just looking a bit beyond out of interest beyond what is usually understandable, but nothing, no significant signals at all. But watch the space, maybe things will evolve. But I had some real interesting questions for, well, interesting for me at least, questions for Siobhan, if that was okay.
Please go ahead.
So, I mean, you showed some amazing examples of how the imaging works, but I suppose from the sudden death point of view, you can see major events such as such as a massive PE or an aortic dissection. But I got a few questions about the pathway afterwards. So if you see a thoracic dissection rupture that appears to have caused sudden death, do you stop there, or would that go on to have a more detailed autopsy to maybe clarify histological types? Would you advocate a genetic sample being taken, given that some of those may be linked to genetic etiologies?
So in my answer, I'm going to demonstrate how I am no threat to pathologists whatsoever, because what I do is I report it and I say, look, there you go, there's a ruptured thoracic aortic aneurysm, there's a significant hemopericardium, or look, there's significant background calcified atherosclerosis. And then I say, have fun with that, move on to my next case. So I think we do have, I mean, I'm not an academic. I am aware that the pathologists then talk to me about various research that goes on, but I honestly don't know what they do next. It's a very interesting question. I will find out though.
And I suppose the question then is, Siobhan, is how, if you're not seeing anything else and then you focus on the heart in an expected sudden death, mm-hmm. or found at home deceased within 24 hours of being well, these sort of definitions that are used for potential sudden cardiac death, how confident do you get about post-mortem CT in diagnosing likely underlying cardiomyopathy?
So cardiomyopathy is an interesting one because it all depends on the interval between death and scanning, because one of the part, Esther will be able to keep me right on this, but part of the process of rigor mortis, the heart on imaging, it can simulate cardiomyopathy. So I would want to be very careful about making a diagnosis of that radiologically. And I'd want to make sure all the timelines were absolutely correct. And I would never do that alone on imaging. I would always discuss it with the pathologist. I have had cases of cardiomyopathy, but I've been happy to call it cardiomyopathy because it's been in alcoholics, known alcoholics, who have been found dead in kind of temporary accommodation or shelters, and who have lots of other sequelae of alcohol excess throughout their body that are visible on CT.
Okay, so I suppose my plea is therefore that the protocol that develops in relation to CT, I think it's got a great place in helping to formalize the pathways for sustaining autopsy practice in the future. But that potential genetic causes aren't always do go to the pathologist, and always do have genetic samples taken at the time so they can be used for diagnostics and for family screening afterwards.
I think that's the real key, Elijah. It's about having a postmortem CT service that works with pathologists and not without. And that the service that Siobhan describes is very much that, isn't it? So the pathologist then sees that report from the CT and decides how to proceed. And then you have the option of, if you've got a thoracic dissection, of doing a limited post-mortem to take some histology samples, to take some genetic samples, so that you can determine the underlying cause, and if there's something genetic, then you've got that material, or to explore a cardiomyopathy appropriately. It's where post-mortem CT services are set up that don't include pathologists that you run into risks of doing a disservice to the deceased and to the family by missing those sorts of opportunities. So I think we ought to aspire to a service like Siobhan's.
Elijah, I wanted to ask you about the the CPVT, so the catecholaminergic polymorphic VT for those of us that are not cardiologists. So do you think that that's fascinating data on the RYR2 mutations? Do you think CPVT is more common in death than it is in life? I feel like I don't see a huge amount of it. Maybe that's the Scottish population. And do you have the sense that those deaths all had exercise involved in them, or do you not have that level of detail?
Yeah, so the phenotype of the cases from the ante-mortem data that we have are that the circumstances of death are that they are generally younger, they're generally male, and they generally die during exercise or stress, which fits with the phenotype of CPVT. There's a little caveat there in that there are new forms of RYR2 disease being discovered now that aren't necessarily typical of CPVT, but may form more in the idiopathic VF cohort. So we may not be recognizing some of those because we don't necessarily recognize very straightforwardly missense variants in RYR2 that are loss of function or gain of function. And in CPVT, it's gain of function, and these IVF cases more possibly loss of function. So that's one caveat from that point of view. In terms of why it's so important, or seems to come out so importantly in death and in life, is I think that the actual frequency of unexpected sudden deaths in children is still very low compared to infant deaths and compared to adolescent and young adult deaths. It's a J-shaped curve. And so the proportion of those that where CPVT may be relevant is actually probably a lot greater than we've appreciated, just because of the low frequency of those deaths overall. There'll be a fraction, there'll be a few in a million per annum in that age group. So I think, sorry, there'll be maybe in the 10s or 20s per annum, per million in the age group, compared to, say, in the wider age group 1 to 35, about 2 to 3 per 100,000 per annum.
Okay.
So I think that's partly just representation of it, and unfortunately a lot of these cases get missed and treated as seizures related to exercise or exertion. That was several of our cases had been to see neurologists before they died, and neurologists had made no diagnosis beforehand just because of the wrong referral pathway being activated. Yeah. Seizures during exertion are clearly not typical of most seizures.
Yeah. Thank you. Esther, there's a question for you in the chat. Whether there's any literature on postmortems performed on those who complete suicide, and whether you feel that would be something that would ever be useful. And that's from Dougie Marks, who's a lecturer in behavioural sciences.
Yeah, thanks, Dougie. In the UK, postmortems are performed on those that complete suicide, or whether in cases where suicide is considered likely. It's part of the coroner's investigations, and here in Scotland, part of the procurator fiscal investigations. So there's plenty of experience amongst pathologists of postmortems in people who've completed suicide. In terms of literature, I'm not quite sure what it is that you would be particularly interested in learning from those cases. I don't know whether you want to add a little bit extra onto your comments, but I hope that's helpful.
So I'd like to, we've just got a couple of minutes left, and I just wonder if I can ask each of the speakers just to comment on in their practice what they found to be the acceptability for patients of discussing postmortem. I feel like in my career I've come a long way on that issue, having felt like it's something that I didn't feel equipped to discuss with relatives and indeed with patients before they die. But now I wonder whether actually understanding diagnosis and having certainty is more important than any discomfort that people might have around the process. I wonder if I can just ask each of you to comment on that from your individual perspective.
So from my perspective, I'll go first if that helps.
Great.
It's very rare that I've been asked, that I have to ask families in my clinical service to undertake autopsies prospectively. So I just see many families, obviously, from my clinical interest retrospectively, and the challenges there are that the interaction with the coronial service and a grieving family who are traumatized by a young sudden death can be very hard, and many coronial officers and procurator fiscal officers will be extremely experienced in doing that, but it can still be very challenging, and there will be a lot of distress around considering retaining tissue and retaining samples, particularly in people, in individuals from cultures where it's not traditional to do so, where it's not acceptable to retain tissue or to delay burial. So I think though it's going to be an ongoing challenge, but it's one that clinicians should try in any way possible to support coroners' offices through by developing pathways between clinical services and the coronial services in a way that will facilitate that sort of information sharing for families and rapid transfer of families into clinical services, so they can understand why these processes need to go through. And that's part of the work that we're trying to do in England at the moment. Thank you.
Esther?
Yeah, my experience talking to families is really variable, and I think there's a huge variation in what families want to know about a postmortem, and some families really want to have a postmortem for their loved one, and some families are dead against it. Even when it falls into the legal system, the coroners or the procurator fiscal service, where they don't get a choice. It has to happen because of the legal process. I had some really interesting experience when I was doing the research study on COVID cases, because I was the one that was taking the consent from the families. I did the initial approach to them. I explained why it was that we were doing postmortems and how they might be able to help us understand about what COVID was doing to people, and how that might help people who were alive and being treated in hospitals. And again, there was a variable response. Some people were not interested at all. They just wanted to get on and have the funeral for their loved one and get on with the grieving process in their way. Some people were really, really keen and interested. They wanted to have the opportunity to benefit other people and use that opportunity for the postmortem. In my current practice, I think it's a real shame, because when we have meetings with families to explain postmortem findings, a lot of the time it's because of complaints or concerns about the process, and that makes it a difficult conversation to have. Obviously we do what we can to explain what's happened, but I think we're missing a trick, really. I think there are opportunities where families could explain things, where pathologists could explain things to families and really benefit families' understanding. But we don't really have a kind of mechanism for that. I'm not really looking for lots of extra work, because we're a very pressed service as it is. But when we do sit down with families and explain findings, and when families are particularly wanting to understand, I think it's a really valuable discussion that hopefully the families benefit from, and I know I certainly benefit from.
Great, thank you so much. I think in the interest of time, we're slightly over the hour, and we're going to have to draw the discussion to a close there. I think my message from this certainly is that the postmortem is not something old-fashioned or outdated, and still has a huge amount to contribute. And it's really just to have physicians think about that, and for us all to set up systems whereby we can have a really multidisciplinary discussion around cause of death and how we do a postmortem, and what's required in individual cases. I want to say a really huge thank you to our three speakers for making this session. To all of the attendees, thank you for coming, and I hope you've enjoyed the session as much as I have. You can please tell any colleagues who missed the live session that they can watch online through the AOP website, And our next webinar is the 17th of May at 5 o'clock, Inflammation Crossing the Disciplines, What Can We Learn? So with that, I will bring the session to a close and thank you all very much. Have a great afternoon.
Thank you.